All right. Good morning, everyone. We were having a little bit of technical difficulties trying to troubleshoot them, but we're going to get started. Thank you, everyone, for joining us here in Pride Hall. We will be in car from now on. So this is the one change. But I'm very excited today to welcome our speakers. Three individuals worked on this talk, and so we're lucky to have them here. And then I want to remind everyone to claim the CME credit. There's an email from Anika Smith that tells you how to do it. It involves texting. There's no more sign-in sheet. So apologies for the change, but please do that so you get your credit. So our three speakers today will be talking about cardiovascular health in people living with HIV. Our first speaker who's here in person is Dr. Matt Hickey, who's an assistant professor in our division. Matt is an HIV provider who sees patients at Ward 86, and his research focuses on implementation strategies to improve delivery of hypertension and cardiovascular disease in rural East Africa. Our second speaker, Dr. Matt Durstenfeld, is an assistant professor in the cardiology division here. He's a general cardiologist at San Francisco General, and his research focuses on preventing and managing infection-associated cardiovascular disease. And Dr. Durstenfeld couldn't be here in person, but contributed to the slides. And then our final speaker is a former faculty member, Dr. Jonathan Davis, who used to be the director of our heart failure clinic here. Dr. Davis is now living in St. Louis and working as a cardiologist at Mercy Hospital. So really three experts in cardiology and primary care here to give us a great talk on cardiovascular health. And Dr. Hickey will start us off. So welcome, Dr. Hickey.
Hi, everyone. My name is Matt Hickey. I'm glad to be here to present together with my colleagues, Dr. Durstenfeld and Dr. Davis. Matt Durstenfeld, unfortunately, wasn't able to be here today, so I'm stepping in and presenting his slides and sort of in collaboration with him and Jonathan. Jonathan, I think, is online. We're working on getting him on the right link, so hopefully you can hear me, Jonathan. But eager to hear your talk, the second half of this. So we're going to talk about matters of the heart, cardiovascular health in people living with HIV. Dr. Durstenfeld and I both receive NIH funding, and Matt also has some Merck funding, and Jonathan Davis has no disclosures. So our roadmap here is we're going to start off talking about cardiovascular disease prevention. We'll talk a little bit about heart failure prevention, sort of a newer topic and still emerging as we're learning what to do to try to prevent heart failure. And then Jonathan will present for the second half on heart failure management. So I'll start off with our first case. This is a 59-year-old man who has known HIV, history of Kaposi sarcoma, now treated, and has known cardiovascular disease, but no prior myocardial infarction. So currently on an ART regimen that includes rilpivirine, TAF, FTC, and dolutegravir. He doesn't smoke, and he was diagnosed with coronary artery disease in 2016. He presented with angina, had a heart catheterization, which showed moderate coronary disease, and he was treated with medical therapy. So no interventions were done, but was started on aspirin, on rosuvastatin, and on metoprolol succinate. So let's just talk a little bit. We'll kind of pause from the case to talk about cardiovascular disease risk in people with HIV. So we know that the risk of cardiovascular disease is about 1.5 to 2 times higher in people living with HIV than someone without HIV. And this is a mix of some greater distribution of traditional risk factors, which is we think of as high cholesterol, blood pressure, obesity, diabetes, tobacco use, stimulants. And then there's also some degree of immune dysregulation, which contributes to added risk. Some of this is the HIV reservoir. Some of it may be just viral non-suppression as well. So if you're not virally suppressed, you have a low CD4 count, that's going to increase risk more. But there's even some residual increased risk, which is probably on the order of about 1.5 times associated with HIV. And then, we thought a lot about risks of antiretroviral therapy historically with some of the older regimens. I think now our increased risk is really likely lipid mediated from PIs, the boosting effect, TAF. And then perhaps abacavir, this is a controversial topic, which I'm not going to dive into, but maybe some increased risk, particularly immediately post-MI. And then, of course, social determinants of health are important components of cardiovascular risk as well. So a couple of years ago, the American Heart Association put together what they call Life's Essential 8. This is a framework for thinking about helping people address their cardiovascular risk, and it really takes a whole person approach. So, we think a lot about medications and risk factor control in medicine, addressing blood pressure, addressing diabetes, obesity with now new tools, and lipids, but really also bearing in mind that smoking cessation, addressing sleep, so getting actually full, sort of close to 7-8 hours of sleep is protective for cardiovascular risk. Diet and exercise as well. So I think sort of equipping people with this framework can be helpful for encouraging some self-management of some of these risk factors as well. Of course, it sort of doesn't need to be said to this group, but HIV control is sort of a key pillar of all of this, as well as we just talked about on the previous slide. Viral non-suppression certainly contributes to higher risk. This is on the right side here. This is data from the San Francisco cohort of both Parnassus and WORD86, looking at cardiovascular risk across all patients. And I think the key message here is that fewer than a quarter of our patients have sort of high cardiovascular health. So really across all of these 8 domains, have what we would consider optimal health. And so there's a lot of room to address risk factors kind of across the more traditional medical risk factors, as well as encouraging lifestyle change for folks. So let's talk about statins and sort of what our role is in thinking about these now post-REPRIEVE study. Of course, we're going to be talking about lifestyle counseling, equipping people with that. But this is a framework here using the pooled cohort equation. So if you Google AHA, ASCVD risk score, this is the one that's going to come up. You plug in the age and lipid panel and whatnot, and you'll get this an estimated 10-year cardiovascular risk. These are the current recommendations on what to do with that risk. And I will say it's a little bit confusing because essentially all of these are recommending statins, basically for everyone. This is based on the recently adopted DHHS guidelines for people with HIV. I am really focusing on this 5% cutoff. So in the middle column, I think there's clear evidence from REPRIEVE with 5% or greater risk, we should be recommending at least a moderate intensity statin. The doses are here. And with a greater than 20% risk, or bearing in mind that the traditional things we think about, if you have diabetes or if there's elevated lipids, we'd be recommending a high intensity statin. This sort of less than 5 category, it's a class C1 of evidence. This is a lower quality of evidence. We can discuss with people whether they want to be on a statin. The doses DHHS recommends are a little bit interesting. They're higher than I would necessarily reach for as sort of my kind of initial dose of a moderate intensity statin. And I think it would be reasonable to do rosuvastatin 5 or atorvastatin 10 for these individuals where they're a bit on the fence, but they're interested in taking a statin to reduce their risk. So I want to introduce as well the more recently developed PREVENT calculator. So this was developed to encompass other risk factors that we know are important, such as kidney function, including EGFR, not just whether someone has diabetes, but what's their A1C, their body mass index, and some social deprivation index. So this calculator was designed to address, over on the left-hand side in the general population, a known challenge that the pooled cohort equation overpredicted risk for the overall population. So the PREVENT calculator was designed better calibrate and incorporate other risk factors that we know are important. However, for people living with HIV, the pooled cohort equation actually slightly underpredicted risk, and the PREVENT calculator way underpredicts risk. And I'll go through some data from San Francisco to demonstrate that. There are challenges with this new, really with both scores, but particularly PREVENT, both in underpredicting risk with calibration and also poor discrimination of sort of identifying who actually does have events. And so my bottom line here is I think we should, for our patients, still keep using the pooled cohort equation. Helpfully, the thing that you find if you search AHA, ASCVD risk calculator, that's the one that will show up. So this is some data from that San Francisco EHR cohort I talked about just a little bit ago, comparing the two calculators. So over on the y-axis here, we have the risk score that's predicted by PREVENT, and on the x-axis, we have the risk score that's predicted by the pooled cohort equations. And you can see here that the risk is just much lower of what sort of the predicted risk is when you do use the PREVENT calculator. So if we apply that to what the recommendations would be for patients in this cohort, which is patients at WORD86 as well as UCSF, Parnassus, with PREVENT, only 29% would be strongly recommended to receive statins versus 2/3 if you use pooled cohort equations. And only 0.1% would be recommended in that high intensity category versus 13%. So we would really be, if we switched to use the new equation, we would be recommending far fewer statins than we would be with this pooled cohort equation. There are greater differences between these scores among men as well as Black people. And so again, bottom line, still recommending using the pooled cohort equations. Sorry, next slide as well. This is really important. So, okay, the scores show different numbers, but what do they mean in terms of actual clinical outcomes? And so this is using the CENIX cohort, so large cohort of 10 clinics around the country, which includes more than 13,000 people living with HIV and more than 600 myocardial infarction or stroke events. And so here we have on the left side, if we look at the actual events that happened on the y-axis versus what do we predict would happen, it's pretty good for the pooled cohort equations on the left. I mean, you can see there's a slight under prediction of actual risk, but overall fairly well aligned. Whereas if we look on the right side, prevent calculator, the actual events are far more common than what was predicted based on that score. Reinforcing again my point, keep using pooled cohort equations for our folks. Okay, so let's come back to our case. So this person, they're on aspirin 81. We've increased their atorvastatin or rosuvastatin sum to 40 milligrams, which is the maximum dose. They're still on metoprolol succinate. And with this medical therapy, they have no angina, excellent exercise tolerance. Symptomatically, they're doing really well. Their body mass index is 29. Blood pressure is 112/81. And then you can see their lipid panel here with a total cholesterol of 184 and an LDL of 107. And then we got a high-res CRP, so looking at inflammatory markers, and that's 1.2. So the question for our audience response here now is, this patient's asking, he's really interested, doesn't want to have a heart attack. So what would we recommend now for this patient? Would we add colchicine? Would we add a PCSK9 inhibitor? Would we add bempedoic acid? Or would we add tirzepatide? We'll let people vote here, and then we'll go through each of these, of course. And then if I advance, Liz, does it show let's see what people are. Okay. Right, okay, do we want to raise hand? Anybody for colchicine? We'll have some in-person participation here. People thinking about that? Yeah. Oh, wait, okay, people are, his LDL is 107. How do we go back? Here's the data. Okay, so colchicine, anybody? PCSK9 inhibitor, you thinking about that? We got maybe a couple. Bempedoic acid, anybody interested in reaching for that? Heard of that? Okay, and then what about tirzepatide? Okay, we got a few votes for that. Great, okay, well, I think these are all good answers. So we're gonna go through and maybe we can see. Oh, okay, we got a few votes here. I guess I'm seeing a different thing here than you guys are up here. Okay, so I think really many of these answers would be good. I'm going to argue that PCSK9 inhibitor, that's what this patient actually received, might be the best answer. Bempedoic acid would be a reasonable alternative if this person didn't want injections. But we'll go through a little bit more information on each of these approaches. Okay, great. So first, we're just going to talk a little bit about residual inflammatory risk. So after statin treatment, this person's on max dose statin. They're taking it. They're doing well with it. What are our options? And so there's really two concepts that we should be thinking about. One is, what's their LDL? How well are we treating their cholesterol? And then two, how much residual inflammation is there? We know from Reprieve that statins can address both of those pathways. But these are sort of the two important things to think about. On the left-hand side, it's a little bit small. And sorry, Liz, we still don't have a way to make this larger. Okay. No problem. So sorry you're seeing very small slides, but if we look at, so this is a study on the left of statin therapy, on the right of ezetimibe therapy. And the bottom line is people that achieved both inflammatory goals, so they had a CRP less than 2 and LDL goals with an LDL less than 70, did the best. So those are people in the red, lowest rate of events. People in the blue, highest rate of events, they achieved neither of those goals. And then actually the middle, the sort of yellow and orange, those are the groups that had either LDL or inflammatory goals achieved. And the lines are really the same. So really, I mean, I think of these as kind of equivalent goals that we should be considering for our folks. How well are we addressing inflammation, and how well are we addressing the LDL? Okay, so let's talk about the role of anti-inflammatory therapy if the high-res CRP is still above 2. This person wasn't. Theirs was good. It was 1.2. But if somebody's high-res CRP is above 2 and we're looking for ways to further address their cardiovascular risk, colchicine is something that we can be thinking about. So there are 2 studies. These are not done specifically in people with HIV, but that are relevant for how we're thinking about it. The first one that I'll just mention briefly, this COLSOT trial. This was looking at post-MI. This is largely in the realm of cardiologists as they're thinking about interventions, but it did show about a quarter of risk reduction in subsequent cardiovascular events. For our patient, this second trial here, the LODOCO 2 trial, I don't know who came up with the name, but this is in people with chronic stable coronary disease. This is our patient right here. Adding colchicine versus placebo reduced the risk of subsequent cardiovascular events by 30%. So that's pretty meaningful. Again, people with sort of ongoing inflammation, this could be a good choice. Who's it not a good choice for? So people with renal impairments, particularly people with a creatinine clearance less than 30, don't use it. People with cirrhosis, don't use it. And then people that are on a boosted PI or boosting agent, Cobi, ritonavir, there are dosing adjustments. So if you really need to reach for it, you can, but I would generally recommend against it because you really need to reduce the dose to avoid, pretty serious nausea, vomiting, diarrhea that can happen with colchicine, certainly if you have too high of a dose. So something we can be thinking about, not the answer for this person, but might be an answer for others with stable coronary disease. Okay, let's talk about PCSK9 inhibitors. So there was a really large trial a handful of years ago now in all the whole population, PCSK9 inhibitors. Bottom line is for people that were on a statin that were already treated with max dose statin, about a 15% reduction in major coronary events, major cardiovascular events. And it reduced the LDL from about 90 to about 30. So really big LDL reductions. There is a study that is ongoing right now, and we expect results, I think, next year that's being conducted by Priscilla Hsu and Matt Durstenfeld in people with HIV. So we're going to have a specific answer for our patients about not only whether this works, but really about mechanisms and what do we see in terms of residual inflammation. So stay tuned for that. We'll have results hopefully next year from this study. But I think in general, extrapolating from the general population, this is a good option for people. Now, it's important to know this is a sub-Q injection every 2 weeks. And so some people that's going to work great. And for others, it might not be a good option. So the next choice that was in that list, bempedoic acid. This is a medication that inhibits ATP citrate lyase. It can be added on top of statins, but you don't need to know the mechanism so much, but it reduces lipids and it reduces inflammation. And so this is something that can be used for people that are already on a statin or they don't tolerate a statin. And this could be given as an alternative. It's a once daily oral medication. And so, it has some, different properties, I'll say, compared to the PCSK9 inhibitors. There was a study from a couple of years ago, the CLEAR study, which showed this reduced MACE outcomes by 15% and about 20% reductions in LDL and in high-res CRP. So we should consider this for people if they have ongoing elevated LDL despite statin therapy, or they can't take it, their LDL is more than 55 and they already had an MI or a stroke, and we're using this for secondary prevention. If their LDL is more than 70, and this is for primary prevention, and we're still worried about high risk, you could use this to add it on. We have an ongoing trial that is enrolling here. If your patients are interested, they could enroll in this study. It's a placebo-controlled trial that's led by Priscilla Hsu, Matt Durstenfeld. I should add my picture here because I'm taking over as the site PI for this with Matt leaving to go to UCLA. Reach out to us if there's people that are interested, but this is essentially going to be a mechanistic study, really deeply understanding what are the mechanisms of this in people with HIV, similar to the Reprieve mechanism study, kind of understanding inflammation and other properties. So there's contact information here and on the slides for later to reach out to us if people are interested. But basically people with known cardiovascular disease or cardiovascular risk factors who are interested in enrolling in a placebo-controlled trial of bempedoic acid. Okay, last we'll talk about GLP-1. So there was some interest in maybe using tirzepatide for this person. I'm going to start with the right side of the slide. Just a reminder, let's talk about semaglutide indications. What are the current FDA indications? So we have glycemic control for type 2 diabetes, cardiovascular event reduction in people with established cardiovascular disease and overweight or obesity. And a reminder that the study that I'll show you, that was a study that recruited people who had already had an MI, a stroke, or peripheral vascular disease. So this is established cardiovascular disease, and we're looking at prevention of secondary events. And then we have, of course, body weight reduction for people with obesity or overweight and one weight-related comorbidity. And then the fourth indication here, which I won't go into detail, but this will come up in other talks, is treatment of MASH, or non-cirrhotic metabolic dysfunction-associated steatohepatitis with moderate to severe fibrosis. So that is another semaglutide indication. Tirzepatide doesn't have indications for some of these yet. I've asterisked. It's really the glycemic control and weight loss for now, although there's ongoing studies to try to understand its role. Given that we know tirzepatide, now has head-to-head data with semaglutide that it's better for weight loss, I think we wonder whether it could be better for some of these other indications, but don't have an answer to that yet. So on the left side, just a reminder of this is the SELECT trial of semaglutide in people with established cardiovascular disease. It reduced cardiovascular events and the primary outcome of about 20%. So this is really effective for people that have already had a heart attack, they've already had a stroke, they're at high risk, and they have obesity or overweight. We could be using it for this indication, both for addressing their weight and addressing their cardiovascular risk. Our patient doesn't quite meet the trial inclusion criteria, but may benefit from this medication for other reasons with his BMI of 29. Okay. I'm going to do the case 2 is short. We're just going to talk a little bit about heart failure prevention, and then we will turn it over to Jonathan Davis online for heart failure management. Okay, so the second case, this is a 68-year-old man who has HIV, hypertension, diabetes, obesity, chronic kidney disease stage 3B, and some nephrolithiasis. This person is on Vic-Taf FTC. Current CD4 count is in the 400s, and their body mass index is 32. With their diabetes, their A1C is 8.3, so not controlled. They're already on a statin. They used to smoke, but they quit, and they have a family history of heart failure, and previously had gotten an echo, which shows a normal EF, but some grade 1 diastolic dysfunction. This person does not have symptomatic heart failure, so that's important. So we're not looking, at somebody that we're managing their heart failure, but thinking about progression. If we didn't have that TE or that TTE result, we might be thinking about prevention, or what are the things that puts this person at risk for heart failure, and how do we address those things? So the American Heart Association recently, is 2 years ago now, put forward the concept of the cardiovascular kidney metabolic syndrome. So some may have heard of this before, but we'll introduce it for those who haven't. And really the concept here is, we've thought a lot about cardiometabolic disease, the intersection of hypertension, diabetes, heart disease. This brings the kidney into this and really sort of frames the central role of visceral adiposity as a common risk factor for all of these conditions, as well as interactions between these conditions. We often see people who have kidney disease develop heart disease and vice versa. So this framework emphasizes the common pathophysiology, and this really informed that PREVENT calculator that I mentioned at the beginning, why we might want to bring in things like kidney disease, BMI into our thinking about cardiovascular prevention. There's also an emerging concept of adipokine dysfunction as a sort of the genesis of heart failure with preserved ejection fraction. So visceral adiposity sort of triggering downstream cascading effects, which not only affect the kidneys, but also may affect cardiac function and cause some of these diastolic dysfunction or preserved ejection fraction that we're seeing. This is a paper that I think is, can't quite see it on the slide, but just out, I think, in the last month. And there's a lot of people that are pushing more of this understanding of visceral adiposity as a driving force of HFpEF. So there's a shift as well towards thinking about, okay, can we prevent heart failure, both HFpEF, but also, HFrEF, which Jonathan will talk about next. We have a really well-established paradigm of cardiovascular disease prevention with the ASCVD risk calculators. We talked about that in the beginning. There's an emerging paradigm of thinking about heart failure prevention. There's a risk calculator. PREVENT also sort of addresses heart failure risk calculation. And some of the steps, these are again for people that are asymptomatic. They're not, short of breath. they're not having nocturnal dyspnea or other things that we might worry about for actual symptomatic heart failure. But this pathway includes using things like BNP or echo or exercise testing to try to push and do screening to see, is this somebody that might have preclinical heart failure? Key question is, there's recommendations for drug therapy, but we don't really have tools yet. I think these will be coming for directly addressing heart failure prevention. Jonathan will talk about management of HFrEF. There are some data for things like GLP-1 agonists for HFpEF for people that are symptomatic, which I won't go into that detail right now, but Jonathan will talk some about in the next part. So really for now with heart failure prevention, where we're at is addressing risk factors. This person has uncontrolled diabetes, really focusing in on addressing that, addressing weight, using GLP-1s to try to address weight. We don't have clear treatments yet for preventing heart failure. I'll just mention one thing that is not yet ready for prime time, but is interesting to sort of, people are investigating this and trying to understand. This is a trial that's very small in people with HIV using a mineralocorticoid antagonist, eplerenone, to try to understand, does this, in somebody that doesn't have heart failure, doesn't have any existing cardiovascular disease, but has visceral adiposity, can this drug sort of improve cardiac function? And they found indeed that it did. Cardiac function was better. There was reduced cardiac strain, less arterial inflammation. There's no clinical data yet on, should we use this and what are the longer term outcomes? But I bring it up just to mention that I think there are things in the pipeline that we may be thinking about in 5-10 years about using for preventive purposes in people that don't yet have established heart failure. Okay, so I'm going to stop there. We are going to turn it over to Jonathan Davis. Jonathan, are you able to hear us? And great, we can see you.
I can. Can you hear me?
We can hear you. Yes, great, Jonathan.
Oh, wonderful.
Over to you. So glad to have you here, joining us online.
Thank you so much. I'm so appreciative of the invitation to still participate. I miss you all so much, and I was very sad to leave and move. I think ultimately the right thing for the family, but we're going to miss dearly the folks at the General and working with all of you. But I appreciate the opportunity to come, still participate. So we're going to move into the case. So next slide, please. So case 3 is a 38-year-old man with methamphetamine use disorder and heart failure. And he's used daily methamphetamine since the age of 16. His echocardiogram shows a severely reduced ejection fraction of 25% with a dilated left ventricle. He's had 4 admissions in the last 6 months for volume overload. And unfortunately, he's had a hard time connecting with us in the heart failure clinic over the last year. Next slide. So this is some Matt Durstenfeld's data that he published last year, looking at a registry of over 3,600 patients. And then about 260 of which had HIV. And on the left side is the age and sex adjusted mortality by HIV, that patients with HIV actually have a significant higher mortality rate compared to adjusted controls. And then interestingly, the right side of the slide is looking at cause of death. So looking at the death certificate of these folks. And again, about 3,600 people overall, about 260 with HIV, and looking at the primary causes of death. And on the left side, people without HIV but did have heart failure, you can see almost half, about 46%, passed away from a cardiovascular cause. And that's really what we see across the board in the cardiovascular literature and heart failure literature. Interestingly, on the right, you can see less than 15% are having cardiovascular as their primary cause. And that dark blue that's taking up just over a quarter, about 36%, just over a third, is actually the HIV or AIDS. So, overlap between the two populations, but you can see really high the morbidity and mortality of having HIV by itself. Next slide, please. But heart failure, just for all comers, is not a good disease. And a lot of the times, and we'll talk a little bit about this, in some of the drugs that we use to treat it. But this is a chronic incurable disease. This is just like HIV or diabetes, where we're trying to use our medical management to suppress the disease, but there's not a cure for it. Looking across the country, the upper left-hand corner here, percent of heart failure diagnosis based on ejection fraction. With red being heart failure preserved ejection fraction and normal ejection fraction, the gold color being reduced, and the blue is the folks kind of in the middle with a 41 to 49% ejection fraction. And it's pretty evenly split between reduced and preserved nationally. But this figure is showing what your mortality is after your first hospitalization for heart failure. So you've come to the hospital, you have a new diagnosis of heart failure. What do things look like moving forward? If you advance the slide 1 click, please. So in the upper right-hand corner, a 5-year mortality. So you can see that the colors for reduced, preserved, and the mildly reduced ejection fraction, the blue, gold, and red, completely overlap. So it's very easy to think that, oh gosh, you have an ejection fraction of 25%, you're in trouble, but your ejection fraction is 55%, yeah, you're probably okay. But that's not the case. Heart failure, ejection fraction is actually a very poor marker of your prognosis. And you can see the 3 lines overlap. And together, click next, please. And one more. So if you look at the cumulative incidence, about 50%, so 50% of people have passed away, regardless of their ejection fraction, by about 2 years after admission. And next slide, please. So if you look at the 5-year event rates, so you can see mortality of 75% across the board. So regardless of your ejection fraction, by 5 years, 75% of people have passed away after that first hospitalization. And if you include readmission over the course of that time, obviously being readmitted is not the same thing as passing away, but almost 100% of patients have had one or the other by 5 years. So a very morbid, very fatal disease. Next slide, please. And kind of putting this in risk. And I think the ASCVD risk is incredibly important. And Matt went over this incredibly elegantly in the first half of the talk. But just, putting the risks of these different populations, again, this is independent of HIV or not, this is all comers. But we think about ASCVD risk and high ASCVD risk here, your 1-year risk of a myocardial infarction or stroke, your high ASCVD risk person is still at a much lower risk overall than your quote unquote stable heart failure patient. So if you look at your quote unquote stable person, they have a reduced ejection fraction, they're NYHA class 2, they're feeling well, they're walking around, they're doing what they want to be doing, there's no reason for hospitalization. Their 1-year risk of being hospitalized or having a cardiovascular death is still much higher than your high risk ASCVD patient. And it's very common to say, oh, your ejection fraction is this, or oh, you're doing great, you're in the clear. But I just really want to drive home the point, much like having HIV augments your risk, that having heart failure really augments your risk as well. Next slide, please. And there's a lot that we can do. And I'll have you just click 4 times, please. Great. So let's leave this up. So these are a lot of medications, and this is the short-term benefit. And you don't have to be on these meds for very long before you get profound improvements in your morbidity and mortality. So the beta blockers, our metoprolol, succinate, our carvedilol, 25% relative risk reduction of death versus placebo within that first month. ARNI, sacubitril, valsartan, there's only one, and MRA, spironolactone, eplerenone, right around 40% relative risk reduction of cardiovascular death or heart failure hospitalization within the first month. And SGLT2, about 60% reduction of death, heart failure hospitalization, or acute care presentation for worsening heart failure. And even within the SGLT2 data, it takes about 2 weeks for that heart failure hospitalization readmission risk to go down. So two weeks and the risk of coming back to the hospital goes down. And then by a month, 60% reduction in these things. So you can see profound benefits of being on these medications. Next slide, please. And then over the longer term, as it turns out, that we just as a medical community are not very good at getting people on medical therapy. And I'll talk a little about some barriers in just a moment. But if you look nationally, most people, unfortunately, across the country are on an ACE inhibitor, ARB, and a beta blocker, this conventional therapy. The rates of MRA, spironolactone are abysmal across the country, unfortunately, something that just needs to be worked on. But the comprehensive, this 4-drug regimen of ARNI, beta blocker, MRA, and SGLT2 has profound impact. And so starting in the bottom left, so advance 1 click, please. So your average 55-year-old, if you put them on this 4-drug regimen, can get about 6.5 years of extra life versus just the 2-drug regimen. And you can see the curves separate really early. And 1 more click, please. So in a 65-year-old, again, a little more competing risks for mortality as you get older, but about 4.5 years of extra life. And it's a lot of drugs. And unfortunately, right now it's been studied. We're trying to publish this and make it more widely adopted, but for a poly pill, but it's a lot of drugs. But you would never take someone with cancer, for example, who needs R-CHOP and say, well, let's just do R and maybe we'll add the C and OMP if we need to. Like, no, they need R-CHOP. They need FOLFOX or FOLFIRI or whatever we're treating. You do the whole thing. It's the whole package, and that's what works. And when I work with patients, they're like, "Oh, do I really need all these drugs?" And, I oftentimes will ask them if they're a sports fan. Are you a baseball fan or a basketball fan? And say, "Yeah, I like basketball." Well, if you're this 5-on-5, you would, if the other team, the disease is putting 5 players on the court, you put 5 players on the court too. You put the full team out there. And it's really how we approach this with ourselves and with our patients, setting these expectations that, hey, you've just been admitted to the hospital, you have this new diagnosis, this is a chronic incurable disease, but it's something we can work on together. We can make you feel better. We can make you less likely to come back to the hospital. We can increase the amount of time, your length of life, but it's going to take teamwork and it's going to take a lot of medications and, setting, true for a lot of things in life, setting expectations, having these conversations early in the process, partnering across the board in a multidisciplinary way to kind of think about between primary care, between cardiology, social work, pharmacy, how can we work as a team to circle the wagons and help folks say, yeah, this is going to be a lot of drugs, a lot of pills, but we got to do it and we got to do it together. Next slide, please. But there are a lot of barriers. So this was really an elegant, simple paper that by Stephen Green and the Duke folks, that they sent out surveys around the country and in different clinical scenarios. And they asked, your patients not on target medical therapy from ARNI, beta blocker, MRA, and SO2, the 4 columns respectively. And why not? Why not? Why didn't you, add the medicine, increase the dose, et cetera? Their blood pressure fine, their heart rate's fine, kidney function, there's no reason not to. Objectively. And you can see across the board, 54, 43, 55, 54, about half the time in all the drugs, the first box, clinically stable and or symptom control. There's just so much clinical inertia, like, you look fine. You look fine. You're okay. We'll talk about it next time. Let's not rock the boat. You look okay. And as I showed you with that risk a couple slides ago, the one with the columns comparing ASCVD risk, that just because they're stable doesn't mean they're out of the woods, doesn't mean they're in the best spot we can get them in. And so when I see a patient in clinic, and I know they have reduced ejection fraction, for example, and first thing I do, it pops up on Epic, I look at their medication list. And if they're not on all 4 drugs, the plan for that day is we're adding 1 or 2 or whatever they're missing. Or if they're not at target doses, I'm increasing the dose. And that is the plan. And then once I have that just fixed in my brain, then I'll look at the vital signs. Oh, well, their heart rate's already 59, or their blood pressure's 91, or I tried increasing the dose before and they made them symptomatic or bumped their creatinine or whatnot, and so I had to go back. But if the default plan isn't this, then you're less likely to make a change. And for example, if someone's coming out of the hospital and the DC team, the discharging team writes, "Oh, please consider starting X, Y, or Z as an outpatient," it's probably not going to happen. But if they provide even a little bit of it, like 12.5 milligrams of metoprolol succinate, the outpatient provider is far more likely to increase the dose. Psychologically, providers are more likely to increase the dose of something than start a new medication. So it really, a lot of this comes down to our mindset and how we approach this. Next slide, please. But what about risks? We're concerned. Like, there are a lot of medications and there are a lot of risks. I'm worried about side effects. I'm worried about this or that with my patient. And so this was a really nice paper published about 2 years ago, where they looked at 17 landmark heart failure trials, and they looked at the table with all the adverse events, and they just compared placebo with treatment. And so thematically on the left, AE is adverse events. Adverse events were very, very common. That about 80% or so of patients in all heart failure trials, including placebo, had some form of adverse events. And remember, patients with heart failure are not asymptomatic, right? They're volume overloaded, they're short of breath, they're coming to the hospital, they're coming to the emergency room, they're not feeling well. That doing nothing doesn't mean that person's going to be okay. And the rates of adverse events overall were not meaningfully higher with intervention than with placebo. And patients randomized to intervention versus placebo actually had lower rates of severe adverse events. What are severe adverse events? Dying, coming back to the hospital. These meds really work to make people's risks go down. And by drugs, individuals, ACE, beta blocker, MRA, SO2 on the right, ACE inhibitors were using very little. The biggest thing really is about 9% this risk of cough, which is obviated obviously if you use an ARB, and you're not going to see that with sacubitril valsartan. Interestingly, as a quick aside, sacubitril valsartan, the ARNI, there's only one Entresto. When they were initially developing the drug, they partnered it with an ACE in the sacubitril, and the rates of angioedema were too high, and the rates of cough were even higher. And then they decided to compound sacubitril with ARB, and the rest is history. And in fact, even I know in 1M, they're using less and less ACE inhibitor as your first line RAS inhibitor, because you obviate the cough if you go straight to losartan or valsartan or something like that. And if the angioedema with ACE inhibitor that you might not see with an ARB, a lot of people are going to be hesitant for good reason to try an ARB in someone with angioedema for an ACE, even though a lot of people would be okay. So you bypass that. Beta blocker are actually less likely to stop the drug. The most common thing they saw was dizziness. MRA, no difference in drug versus placebo discontinuation. The big thing is the gynecomastia. If you have a male patient who starts complaining about breast tenderness, breast swelling, breast soreness, I notice my breasts, I feel just switch them off spironolactone. The longer someone has spironolactone or has gynecomastia from spironolactone, the longer it can take to go away. So I actually had someone who had it for over 2 years, just never said anything. Maybe I should have asked, but never said anything. And it took years to go away, and actually even had to go see plastic surgery. So if someone has anything concerning even sniffs of gynecomastia, just stop spironolactone and go to a eplerenone. We're not going to talk today about finerenone, the new non-steroidal that actually now has FDA approval for heart failure with preserved ejection fraction. There's not really any data for finerenone to reduce ejection fraction. There's a lot of clinical trials ongoing. The best data really are in patients with chronic kidney disease and proteinuria, which is a little bit beyond the scope today. But just overall, MRA is very well tolerated. It's the potassium that you have to follow. And then finally, SGLT2 inhibitor. Now, overall, very well tolerated. More people stop the placebo than stop the study drug. The biggest thing to really watch out for are the genital infections. I'm not sure where they got the 0.9% higher rate. The rates are definitely higher, especially in female patients have a much higher rate of having the mycotic infections. And then it's also related to hygiene. Circumcised men have less than uncircumcised men. And a lot of this is directly related to your degree of hyperglycemia. So remember, SGLT2, they block the sodium glucose transporter that makes you have more glucoseuria based on your degree of hyperglycemia. So folks that have blood sugars in 3, 4, 500s, very high A1Cs, have a lot more glucoseuria. If you're euglycemic or non-diabetic, your rates of glycoseuria are exceedingly low, which is why people thought this was going to be a great diabetes med, because the rates of hyperglycemia are low. But really, a lot of the side effects that we're seeing here, the rates of DKA, dehydration, genital infection, are very closely tied with your degree of hyperglycemia, how well your blood sugar is controlled. But overall, very well tolerated. And the last thing I want to say is the rates of urinary tract infections, your run-of-the-mill E. coli UTIs, that in diabetic patients, specifically diabetic female patients, the use of SGLT2 is protective against having UTI. You don't believe me, it's beyond the scope of the time we have for today. Go back and look at EMPA-REG outcome from October 2015, the landmark SGLT2 paper, the very first one, and go back and look at the figure, and you'll see that 5% absolute risk reduction for women with diabetes for having a UTI. So next slide, please. But I really do want to spend some time talking about a major comorbidity, which is methamphetamine use, which, as we all unfortunately know, the prevalence in San Francisco has just skyrocketed over the last couple of years, as you can see from from the figure here. Next slide, please. And in California, methamphetamine use associated emissions increased by 600% from 2008 to 2018, 1.2 to 2008. Unfortunately, only continued to rise as the prevalence of methamphetamine use also continues to rise. And patients who have SACMP, stimulant-associated cardiomyopathy, have almost a 4x the odds of a heart failure readmission compared to people without stimulant use. So very common, prevalence rising, very morbid. Next slide, please. And methamphetamine can have a lot of different toxicities on the heart. It can cause a cardiomyopathy, cause malignant hypertension, and coronary vasospasm, even so bad that it can cause an acute MI. It can also just increase your risk of having primary coronary disease, independent of vasospasm. You can just have more atherosclerotic buildup and be an accelerated coronary disease. It can cause pulmonary arterial hypertension and cause sudden cardiac death. I think what's most interesting about this, and there's a lot of unknowns here, is it's probably a two-hit hypothesis, that you'll see plenty of people that have methamphetamine use and an ejection fraction of 15%, or methamphetamine use and severe pulmonary arterial hypertension. But the folks with pulmonary arterial hypertension usually don't have left ventricular, left-sided disease. And patients that have an ejection fraction of 15%, usually the pulmonary pressures are only bad because of the left side of heart disease, not from a primary pulmonary process. And for the hundreds of people I've seen with stimulant-induced disease, only a handful, fewer than a dozen, probably even fewer than half a dozen folks that I've seen, again, anecdotally, have both pulmonary arterial hypertension with a PA pressure that's through the roof and have an ejection fraction that's severely reduced. So there's probably some genetic predispositioning factor. One of the fellows a few years ago started to look into this, but then fortunately for her, she graduated. Unfortunately for us, the research got paused. But there's probably some genetic predisposition where they're predisposed to cardiomyopathy or pulmonary hypertension, and the methamphetamine use is that second hit. Because we also see people that have used methamphetamine 17 times a day for 25 years, and they have no cardiopulmonary disease. So there's definitely something that we just haven't identified yet. Next slide, please. So people with stimulant-associated cardiomyopathy, again, I already mentioned, have higher rates of mortality, more acute care utilization, and lower rates of consistent outpatient care engagement. Next slide, please. So there are a lot of barriers. There's, as I mentioned, there's unknown pathophysiology. We don't truly know the incidence. I've reviewed quite a few papers for various journals, of folks looking into this, and just the definitions are across the board. They'll have an inclusion criteria of, any positive urine drug screen. Well, that is not the same. One random urine drug screen is not the same as someone who uses multiple times a day for years, or one person who used one single time. They're very different phenotypes, but a lot of times these folks are getting lumped together in clinical trials or cohort studies, I should say. Continued stimulant use drives disease progression and impedes medical care. There are limited effective treatment options to reduce use. And there's a lot of stigma associated with this. So providers can also be similarly biased against the patient potentially because of their drug use, and that further widening the care disparity. Next slide, please. So there are a lot of issues. So, and I'll go through this quickly because we're all familiar with this. That stimulant-associated cardiomyopathy, so folks with heart disease and stimulant use, that they're disproportionately disenfranchised communities with inequities in care access and resources. They're the social determinants of health that go along with this in terms of housing, income, employment, ability to work, co-occurring mental health issues, and other substance use. So lots of barriers that this population will face. Next slide, please. And interestingly, so I mentioned the benefits of the medical therapy, the beta blockers, MRAs, et cetera, but just stopping use can also make the heart get better. It depends on how long the heart's been bad for. So if it's a more recently developed cardiomyopathy versus someone who's had this for many years, but just all comers, this was a nice paper from Jack from 2017, so a few years ago now, but just looking at folks that had a reduced ejection fraction who continued use or were able to get into remission, you can see that the ejection fraction stayed low in continued use, but increased significantly with cessation. The primary endpoint of death, non-fatal MI, or heart failure readmission, significantly fewer people if they're able to stop using. And heart failure symptoms also dramatically improve. So symptomatically better, comorbidities better, and mortality better, all by, if you could just, it's obviously much easier said than done, but just having a focus if we can get someone to stop use. So ideally, reduce use, and so take away things that hurt the heart, add things that help the heart with the heart failure meds. So next slide, please. And treatment options are limited. So medical therapy is often suboptimal just across the board for the general population, but even worse in this population. There are no specific FDA medications approved for stimulant use disorder. And contingency management, though, is a highly effective behavioral treatment. So we can go to the next slide. So thinking about, if you have any stimulus in any behavior, so we want to increase or decrease the behavior, and do we want to benefit the person? So add something or take away something. So the contingency management, we want to increase the target behavior by adding something with positive reinforcement. So next slide. So that's really what we're going for. So this is the genesis of Heart Plus, and this is one of the things I'm going to absolutely miss the most about not being in San Francisco working with y'all, is being part of the Heart Plus clinic with the addiction medicine folks who've just been such wonderful partners over the years. As I go through the data for this and the infrastructure for this, I should say that the addiction medicine clinic, the Bridge Clinic, is still very much intact and is incredibly built out. Just like Ward 86 has tremendous resources. The infrastructure still is for Heart Plus. We're searching for a new cardiac champion. Christina Ryan the heart failure nurse practitioner has really stepped up to be the face of this from the cardiology side. So we want to have this continued because we've done a lot of work to have this built into the workflow and the infrastructure of the cardiology and the Addiction Bridge Clinic. So I think this is a great program. I'm going to go through some of the data for it right now. And I think this is really something that we've done enough laying the groundwork for, that this is something that continue for years to come. So next slide, please. So it's a twice weekly clinic structure. So they meet with twice a week with the addiction medicine specialist, doing motivational interviewing, talking about contingency management, talking about medication use, talking about their symptoms, talking about their substance use. You see the cardiologist at least once a week, at minimum every other week, depending on how their heart failure symptoms are doing. And each visit, like vital signs, focused cardiovascular exam, and optional point of care urine drug screen. Next slide, please. So the fishbowl. So this is for the contingency management, that there are 500 slips of paper. Half the slips are written affirmations. Way to go, good job, keep it up. And the other half are for gift cards. Most commonly for $5, $10, and $100. When we first piloted this, we actually had half the cards were for Target and half the cards were for Safeway, with different monetary denominations. And this was before Target really had grocery stores kind of built into them. And what we noticed is that no matter how much money a person won that session, that almost no one wanted the Target gift cards. They all wanted the Safeway gift card. They all wanted the food option. And so we actually stopped getting Target gift cards and just used Safeway. Next slide, please. So when they first start, they get a priming draw. So they keep drawing until you win money. And then the second visit, they get to draw the number of times that they show up, and then they get to have the option of providing a urine sample. And the more consecutive visits you have, the more draws you get. The more consecutive urine drug screens you have, the more you have. So you can show up and not want to pee in a cup, and that's fine. You still get the draw for showing up. And the cost is actually very low. So on average, perfect attendance, urinary drug screens all negative, about $600 per patient. Now, about half that if they show up half the time. And our 10-patient pilot, we assumed $3,000 in gift cards. So next slide, please. So our initial cohorts of this, our first iteration of this was March of 2020. We had 1 week, 2 sessions, and then everyone knows what happened after that. So we kind of picked back up in 2021 with some telephone, some in person. And then by 2022, we were all in person again. So over 22 people over this time. You can see primarily men, 1 woman. The race ethnicity breakdown, about 50% housed, 50% marginally housed or unhoused, about 60% methamphetamine, 36% cocaine, and then 1 person used both. And then at the beginning, very bottom, you see their BNP is very high, about 1,000, and their ejection fraction was about 35%. So very, very sick group of people. Next slide. And median of 13 visits. And by the end of the 12-week program, 3 patients had stopped using completely. All patients had reported a reduction in use, self-reported, and all had reached the maximally tolerated doses of the 4-drug regimen, beta blocker, MRA, et cetera. So it really worked for this group of people. Next slide, please. And the 2 things that we were looking at, in blue is acute care. So how often are these people going to the emergency room or being admitted? And in orange is how well are they actually showing up to clinic. So blue is the number of all-cause presentations, so whether they're admitted to the hospital or coming to the emergency room. And you can see in the 3 months preceding Heart Plus to the 3 months during Heart Plus, with over a 50% reduction in the acute care presentations. And then it started to drift up in the 3 months afterwards. And conversely, their clinic show rate went up from less than 20% to about 80%, and then unfortunately started declining after the program. And this really informed that for the right patient, this was a highly effective intervention, but also that we had to do something after this 12-week program. We started something called CODA, which was once a week with addiction medicine and with cardiology to try to help ease that person out of the program and back into regular primary and cardiology care. But just cutting them off abruptly was not the right strategy for most of these folks. Next slide, please. And I want to read these. So at the end of our initial pilot, we did exit interviews and kind of looked at some thematic analysis. But I just want to read some quotes from these three themes. So the first theme, non-stigmatized care facilitated hopefulness. To have a people who give a damn and don't judge you because of what you do or your lifestyle, that's a miracle and a blessing in itself. And to see people give a damn, it's like, wait a minute, they care so much about me, maybe I should care about me. Theme 2, patient-provider relationship is essential. When my doctor pops up behind the glass and she acknowledges that I'm here, that I'm present, it always feels good inside that I have a person who's rooting for me all the steps of the way. And it always feels good to have somebody that's walking with you through the darkness. And finally, theme 3, Heart Plus changed participants' view of their health and drug use. When I came here and I said, oh, I don't crave that much today. I'm clean. I'm supposed to be getting high. You know, this is not me, right? I notice that my using is fading away and hopefully it'll be for good. So just profoundly, profoundly impactful for these folks. Next slide, please. And for only half a dozen of folks, we actually in 2022 were able to get pre and post echocardiograms. And you can see for the 6 people that the median EF improved from 23 to 52% over the course of the program, which is really just incredible, both less methamphetamine use and more cardiovascular medication use. Next slide, please. So just to recap the last 4 points and then see if Matt Durstenfeld has anything he wants to add, and I'll turn it back over to Matt Hickey. Just thinking about preventing heart disease among patients with HIV with statins, consider additional CVD risk reduction, thinking about the lipid profile as well as markers of inflammation. I know there's a question about checking lipo(a) and ApoB and high sensitivity HSCRP. Maybe I'll let Matt Durstenfeld or Matt speak to those things too. I can be happy to as well. That quad therapy, medical therapy for heart failure saves lives, improves quality of life. And thinking outside the box of multidisciplinary ways, getting out of our own silos, which Ward 86 does so incredibly well, really sets the benchmark for multidisciplinary care for these folks. And so with that, I believe that's our last slide.
Fantastic. Thank you, Dr. Davis. Thank you, Dr. Hickey and Dr. Durstenfeld. That was fantastic. Why don't we tackle the CRP lipoprotein A question?
Yeah, this is Matt Durstenfeld. Happy to answer that question, and sorry for the scheduling challenge. But so basically, the evidence for colchicine is really in post-MI patients or patients with chronic stable coronary disease. So that's patients with revascularization or with angina being treated medically. So those are typically the patients I think about checking it after they've been on a high intensity statin. And then lipoprotein(a) and ApoB can help clarify someone's lipid risk. So in somebody with a strong family history, or really for secondary prevention where they've already had an MI or revascularization, that's when I tend to check it.
Great. Thanks so much, Matt. And just to add to that, I mean, for people with primary prevention, how often are you checking those measures for people that are already on statins? Maybe they're interested in what else could I do to reduce my risk?
Yeah, we do see some consults for people who, are very worried about their cardiovascular risk. And so I do sometimes check that. It's mainly if patients have other risk factors like a strong family history that may not be captured in kind of our normal risk calculators. And then there are new lipoprotein(a) treatments that are in the research pipeline. And so once we have FDA approved treatments specifically targeting that, I anticipate it'll move up to include primary prevention.
Great. Why don't we just see if there's any questions in the audience? Dr. Jane. There's a mic.
Oh, thank you to both of you for those fantastic talks. Really quick question. Are coronary CTs orderable for us here at ZSFG?
I can answer that question. We can order coronary CTs, and there's 2 different kinds. So the one that we can order is a CT angiogram, as opposed to a calcium score, which is not covered by insurance. The calcium score comes with the angiogram, but we don't usually use that for risk stratifying patients for primary prevention. It's more for workup of chest pain, particularly if it's lower risk and the patient's younger than 65 or so, where we think that we want to know, do they have any coronary disease at all, that we might want to really think more about putting them on a statin. And secondly, are their symptoms actually being caused by obstructive coronary disease?
Thanks. And sorry to add a small second question. Could you just share your view on this new emerging kind of polygenic risk scores? The idea that no matter everything we do, if we do it perfectly, we still fail to capture a certain amount of coronary disease risk. There's a new test. I think it's gone live from Mass General. It's now orderable. Just your perspective on going into the genetic layer on this. Thanks.
Yeah, again, a great question. There are different ways people approach trying to predict someone's risk. One is thinking more about like the lifestyle score, like the AHA's Life Essential 7 or Life's Essential 8, which I think should be 9 for HIV. So that's like lifestyle factors, thinking about genetic risk. And so that's like the polygenic risk score that's now available through MGH. I think one particular question for people with HIV is we really have no idea how those scores translate. They haven't been developed, tested, or validated in any populations with HIV, and whether that underlying genetic risk is kind of overwhelmed by the additional risk from HIV, or whether it's additive is really unknown. But I think particularly for younger patients, where you're thinking more of like a lifetime prevention strategy and how aggressive to be at a younger age, particularly before age 40, is where those scores, like in somebody again with a strong family history, but with a normal lipoprotein little a, that's kind of where I think about polygenic risk scores really being helpful.
Okay, wonderful. We're going to have to wrap up, but thank you to the three of you. That was fantastic, super educational. So thank you again, and sorry for the technical difficulties.